Aliko? Ready? Okay. Good morning. Good morning, everyone. Thank you. Welcome. And welcome to all of our distinguished guests as well. Yes, I welcome you to Chatham House. I welcome you to the Public Health Africa Policy Forum. My name is Dr. Ngozi Arandu, and I'm a senior research fellow here. I'm co-chairing this event with Professor Aliko Ahmed. So that's your first welcome. Can you see it? Okay. So before I get into the presentation, I'm going to talk a little bit about some house rules. So is this anybody's first time at Chatham House? Ah, excellent. Okay, good. So that's an extra welcome to you all. So just really quickly, you go out the door, up the stairs, and to the right, you'll see the restrooms. If there's a fire, we pray that there won't be. It's just right out that door. So everyone knows about the Chatham House rules. Usually it's what happens in Chatham House stays in Chatham House. But today, this is actually being, exactly, it's not the case today. This is being live recorded. So our colleagues back in Nigeria could be part of this with us. So the Chatham House rules do not apply here. So just a quick review of the agenda. You all might have it in front of you. I'm going to give a quick overview and set the scene a little bit about who we are here at the Public Health Africa Policy Forum. After my quick presentation, then we'll have Mr. Rob Yates talk about UHC in general, and then we have some presentations from Professor Aliko Ahmed, the Honorable Minister, the Senator, and some other distinguished colleagues as well. We only have 2 very precious hours today, unfortunately, but I think that we can get some meaningful conversation and discussion in these 2 hours. We'll have a panel discussion with question and answer at the last hour of our time together. And this will be the opportunity for the audience to ask questions. But again, since we have a very short period of time, what I was thinking is that during the meeting, if you have questions, you could write it down and give it to me or give it to Ali. Ali's not here, but Ali was the young lady that welcomed you as you came in. We'll both be at the back, and you're welcome to just write it down, and we can provide that to Professor Ahmed, who will be moderating the session. And then after that, we'll conclude, and we'll tell you about something that's really interesting happening at Chatham House that we would like to invite you to, but that's to the end. So you actually have to stay to the end to find out. All right? Oh, I also wanted to say one more thing. So this policy forum, it's really easy to talk about all the problems with Nigeria, but we're really focused on what are the solutions, and that's why we have the Honorable Minister and our other distinguished guests here to tell us about their plans. And we'll look at the last 4 years, but we're really thinking about the next 4 years and going forward. So when you think about your questions, please think about that. What are the solutions to public health in Nigeria? Okay. All right, so just about the Public Health Africa Forum. Our objective is to facilitate the development of evidence-based policy options that are relevant and appropriate to sustainable health developments in Africa. And so this is very much in line with the Chatham House mission, which is to build a sustainable, secure, prosperous world through informed debate and intelligent analyses. So our convener, who is Professor Aliko, he established this forum to really uphold the tenets of Chatham House, but we really are focused on building partnerships in Africa with collaboration with our colleagues as well as institutions. And we have an ethos to build up the strength of Africa, to improve health, and focus on what matters the most to people. But I do want to emphasize 2 of the words on this slide, which are relevant and appropriate. I think you can get policy analysis in all sorts of ways, but when you have people from the actual country, people who work in these governments, then you get context-specific policy. And so that's what we really want to drive here at the Public Health Africa Policy Forum. Okay, so what type of things do we do? So some essential activities are informed debate. We have policy research and in-depth analysis. We provide policy options and recommendations. And we have country-specific and regional emphasis and expertise. So we had 2 events in the past 2 years. We're a new forum, but we will be picking up our activities. But was anybody able to attend any of these events that are on the screen? Oh, I know Honorable Minister, you were there. Yeah, thank you, thank you. So that's great. So we were really privileged to have some of the past speakers at this event, well, some of the speakers at this event, at that event as well. We had high-ranking government officials, including ministers of health, senators, state governors, senior WHO officials, including Dr. Tedros and Dr. Ibrahim Soke Fall, who is the new director of the newly established WHO Health Emergencies Program. So, like I was saying earlier, all of these activities that we do this in co-production with our colleagues and stakeholders in Africa. We aim to provide well-informed and credible research and analyses. And also I want to just emphasize something else that we don't always think about too much when we're talking about public health, and that is intellectual assets. So oftentimes when we're talking about public health, we're looking at what we can bring in, what are the interventions, what is the new technology. But we know that Africa has its own assets. Every country has its intellects, they have their systems, they have the culture. And so what we're doing at the forum is really trying to build on those existing intellectual assets. We're building on the strengths of what we already have. And so one of the questions that we're asking today is, how do we strengthen health promoting assets in Nigeria? All right. So like I said, we're a new forum, but in the future, we want to start asking some more questions, convening some more experts and government officials to focus on issues of relevance, appropriateness, and sustainability. So here are just some of the topics that we will be looking into in the future. If anything really grabs your attention, let us know, and we would love to include you in these future events. So just a little scene setting for what our speakers are going to be talking about very soon. I think we all pretty much know that we are in the second term of President Buhari's administration. The first term began in 2015. Today's focus is really from 2015 to today. So there might be a lot of things that we want to talk about or what happened before 2015, but okay, but I found this picture online, sorry. There might be a lot of things that we could talk about before 2015, but we really want to understand what type of impact, what type of changes have happened since President Buhari was installed into office. So yes, the focus of today's talk will be reviewing the success and challenges of the last 4 years and then considering the priorities for the next 4 years. Okay, so from the president himself, we all know that universal health care and universal health coverage, I would say, is important to Nigerians. It's a right for Nigerians. And so I entreat you all to engage with these topics over the next couple of hours. I wish you a very good meeting. And now I would like to introduce Mr. Rob Yates at the Chatham House, who will be providing a global update on UHC progress. Thank you.
Fantastic. Many thanks. And just a quick welcome from myself, and welcome back to Chatham House for a number of you. It's wonderful to have you back in this space to be able to talk about universal health coverage, the financing of universal health coverage, and also I hope we get into the politics of the financing of universal health coverage, because as we recognize all around the world that really this is more political than it is technical. And we can see, here in the UK, in the United States, all income levels, we're all grappling with the same issue as, how do we make sure everyone gets the healthcare that they need? So I've just got about 10 minutes to sort of try and put where you are in Nigeria in a global context of universal health coverage, but also flag a couple of major developments that are happening in the continent of Africa that you might want to take a look at. So first of all, just to go back to the definition of universal health coverage, is that all people receive the quality health services that they need without suffering financial hardship. Notice there's nothing about insurance in that definition. People often sort of make this assumption that the UHC is all about people having health insurance coverage. There's nothing in the definition about insurance. And we here in the UK, with our fantastic NHS that we all love, we do not have a formal health insurance system. So you don't need to have health insurance, specific health insurance, to have universal health coverage. From that definition, you can see, I mean, it's quite a simple definition. There are three bits to it, aren't there? It's the universality, everyone being covered. It's about people getting services they need, and financial protection, those three aspects. But really, from that, it immediately falls that it is all about equity and fairness, which takes you into the realms of rights and the politics. First of all, that we are talking about everyone in the country, all age groups, migrants, everyone being covered. The people aren't excluded. We're talking about services allocated according to need, recognizing that objectively some people need more health care, obviously those with sort of chronic or acute sicknesses, but also pregnant women, children, elderly people, disabled people. They need more health care, therefore they should get more health care. And then this very important financing aspect. If we are going to have financial protection for everyone, automatically it follows that you need a financing system that rich people pay more than poor people. You can't do it otherwise. Otherwise, poor people just wouldn't get the services. So in effect, what you're talking about is healthy, wealthy people subsidizing services for the sick and poor. That is the foundation of universal health coverage. Now, that leads you to some pretty profound findings about how you finance your health system. And this has been an extremely controversial topic over the last 20, 30 years, but there is now this consensus. The World Bank, the IMF, all major economies, WHO, UNICEF. There are a few exceptions, maybe sort of right-wing Republicans in the United States who don't sign up for this, but they are wrong. And if you really want universal health coverage, this is the consensus, that a market-financed health system where people buy and sell health services as you would buy a restaurant meal will never, ever take you to universal health coverage because you don't get the cross-subsidies. It just won't work. And again, you've only got to look at the United States with its highly privatized health financing system to recognize that you can spend 18% of your GDP and still have 30 million people without access to health care. Instead, there is this role for the state. It has to be compulsory. The state has to force healthy, wealthy people to cross-subsidize the sick and the poor. And really what you're trying to do is move away from private voluntary financing, that you decide that you want health care for maybe you and your family, but you're not really bothered about what happens to other people. You move away from this sort of private financing to more compulsory public financing. But this also goes for insurance too, that private voluntary health insurance will not take you to universal health coverage because you don't get the cross subsidies again. And it's regressive. And so, this idea that, we might have a system whereby, the state might just sort of cover, the poor, and we expect people to take out voluntary insurance never works. And, there are hardly any countries that are even trying it these days, apart from the United States soldiers on with it. So, but moving to this system where you're forcing healthy, wealthy people to cross-subsidize the sick and the poor is inherently political and will be resisted by the vested interests that want to maintain a privately financed system. And so the trick is, for those of us in the health sector, you have to engage the politicians, and in particular, the head of state. We've already had President Buhari mentioned. It really is around the head of state, or maybe state governors, taking the lead in recognizing this is what should be done. And here are sort of a couple of slides to illustrate this transition to UHC. These are Asian countries, and you can see sort of bottom right, these are the countries that you associate with UHC. They have a publicly financed health system, relatively high levels of public spending as a share of GDP, which tends to crowd out this private voluntary financing. So you can see that countries like New Zealand, Japan have less than 20% out-of-pocket spending. And that will mostly be sort of rich people sort of choosing to buy private health services. That's fine. And that's pretty close to UHC. Top right, you have countries, very low public spending, people just buying and selling services. It's very inefficient, very inequitable. The poor people don't get health services. That's where you don't want to be. And the transition to UHC is basically about moving down that curve. Now, you're saying that's Asia, we're here talking about Africa, why has he done this? Here's the African picture. And this is a slide that I think I produced the last time a number of us were here, sort of showing countries that have done pretty well again, moving sort of bottom left to having what we could call a socialized health financing system. But you'll notice Nigeria is right up there, top left, sort of just being absolutely frank here. Now, that's 2014 data, and I actually looked last night at the latest data. I need to redo this graph. 2016 data, so you might say that's 2 years of the president's first term. I regret to say that Nigeria has moved northwest slightly. I think the latest GDP per capita health spend is 0.47% of GDP, and out-of-pocket spending 75%. So you can say that was then, and this is now. So one would hope that second term, there's going to be a sort of a greater effort to sort of move down the curve. But this is all about taking this agenda to the political leaders to make those decisions to increase public spending and take you down that curve. Someone who's doing this, of course, is Dr. Tedros, is engaging heads of state and state governors to have this discussion about sort of taking leadership in publicly financing the health system. And I just want to mention, we were sort of talking about putting everything into context, a couple of big developments in Africa at the moment, one in East Africa, one in Southern Africa, and something for you to watch out for. Kenya is launching big UHC reforms at the moment. The president, about 18 months ago, made it a priority for his second term that he was going to make UHC one of what he called his 4 development pillars. But he's increasingly recognizing that actually health reforms are something that he can do in his presidential term. That, he is also continuing with his other reforms in, I think, housing and agriculture and jobs. But in terms of big bang impact, it's going to be his health reforms that he's going to be remembered for. And he's launched reforms in 4 pilot counties. And what he's done is basically made it universal free entitlement to publicly financed health services in those 4 counties. No insurance contributions whatsoever from the informal sector. Now, the formal sector pay into the National Health Insurance Fund through their salaries, but really it's the case that in those 4 counties, if you're a resident of that county, you get free state-financed health care from the primary health care level right up to the hospital level, but with referrals that people can't just go straight in at the top, which is the case here in the UK as well. This is proving very, very successful. It was only launched in December. There's been a doubling in the utilisation of health services in those counties so far. And the expectation and hope is that this is going to get rolled out across Kenya, maybe even as early as late this year on December the 12th. So watch this space on this, but it looks as if Kenya is going for big bang universal tax-financed health services. Now, that's in East Africa. In Southern Africa, there's a very high expectation that President Ramaphosa is going to do exactly the same thing. That he's fighting the elections, I think, that this week, aren't they? Maybe next week. Very significantly, he's moved the health reforms into the presidency, where he set up what he's called a war room to take control of this, to put real political commitment by the reforms, which will see a National Health Act come in that will force the healthy wealthy to cross-subsidise the sick and the poor with a universal entitlement to services. So you can see that Kenya and South Africa are largely doing the same thing. This model works. This is the famous Thai model. It's what they've done in Cuba. This system works. What it's crying out for, of course, is who is going to take the lead for this in West Africa. There isn't a good example in West Africa at the moment of a country doing this. You'll be aware that your neighbours and, dare I say, competitors in Ghana started some reforms about 15 years ago, but it's not universal. It's an insurance-based system. They've only reached 39% coverage after 15 years. It's an open goal now for a country to implement these types of reforms in West Africa, and it would be absolutely fantastic if Nigeria could do that. Anyway, that's my introduction. I'd like to now hand over to Aliko, my colleague Aliko Ahmed, who's the convener, of course, of the Public Health Africa Policy Forum. He's also an associate fellow here at Chatham House, and he's also a director of Public Health England in the east of England. So Aliko, if I can hand over to you now. There you go.
I need the click there. Yeah. Thank you very much, and good morning, ladies and gentlemen. It's great to see you around. So many of you that were here when we had the event in September about 2 years ago. I was surprised when you asked. There wasn't so many hands, but I could see so many faces, and certainly our speakers here were there at the first event. Well, this is a session, I think Ngozi has said it quite well in terms of what we expect. So much has been known about Nigeria. We're very good in the diagnosis of Nigerian health challenges. This is intended to be more a solution-focused approach to that. So I hope that will be the spirit of the day. Somebody asked me, why do we have this meeting in Nigeria, in London, not in Nigeria? But I thought the question was a bit myopic in the sense that Nigeria has always been global. Nigeria is a country that has been part of the global community for so many years, and it will continue to be. Nigerians are everywhere, just more than 1,000, from what I understand, more than 10,000 health professionals alone in Nigeria. That's in the UK. So Nigerians have had a good, long historical linkages outside Nigeria. And this is a poster I got from my good friend, Dr. Atta, to show you how Nigeria has been discussed in the UK then. Although the narrative may have been reversed, but we want language to go back to where it was, because this is what Nigeria used to be, a great nation. And I think with the potentials we have, we should be able to address that. So as Desmond Tutu said, language is very important. The more you talk about a negative narrative of a place, the more the reality becomes. So I think that is a lesson for us all. So sort of think about the language of solution doesn't only mean that we just sit down on our desktops and complain about situations, but looking at how solutions can truly be done. And policy making in itself is a microcosm of different skill set, different assets, different responsibilities. But what is much more crucially identified is the role of the political leadership in it. That's why I'm so delighted we have the two main key players in Nigerian policy cycle here today. And I hope we will hear a lot about what had happened since 2015. We also have members of the panel who will bring very incisive issues about professional domain and democratic sort of languages and development in Nigeria in particular. What are we aiming to get today? I think there are two things that potentially that we want to get out of this session. The time frame, as Ngozi said, is 2015, because that's when this new administration starts. So what we want to look at is some sort of an identification of the critical success factors or challenges that happened over the last 4 years. And then the second outcome of it will be, we want an articulation of what will be perhaps the priorities for the next 4 years. And then lastly, we want to share our exciting new program that we are looking at into Nigerian health policy and try to invite you to be part of that. The session today is in the outline. What we will start with some presentation from our key players, the Honorable Minister and the Senate Chair of Health Committee. They were here about 2 years ago. And I think in that session, it's fair to say that one of the things that came out of that deliberation was an acceleration of many things that had happened in Nigeria that had been celebrated, which we'll hear: the 1% consolidated revenue, the better healthcare provision fund, so many things that had happened. And I think the role we played in that last session here has been catalyzing, to say the least. If I can just move quickly into what will happen. So we'll have 10 minutes presentation, hopefully from the Honorable Minister and the distinguished Senator. We invited Dr. Nduka Opegbina from the Chatham from this day. Unfortunately, he hasn't arrived yet. I hope he's on transit and he'll be able to be here. It will be a 10-minute session. I think if you ask the two gentlemen who will speak, to speak the whole day, they can on those sort of achievements. So the 10 minutes will be just a summary, and then we'll have a panel discussion. The panel discussion will invite two of our colleagues also, Professor Ladi Hamalai and Professor Hadiza Galadanchi Tudel. We want to spend a bit more time on the panel discussion. And in typical fashion, I've had 45 questions from Nigerians across the world in terms of what I should ask the minister and the senator. So we are not liking for questions today, but I will really hope there will be also questions coming out from here, because then we can get into the real heart of the issues in itself. So I think without taking much time, I will probably just move on now to introduce our first speaker. And in true protocol of sort of Nigerian style, I will try to avoid the long introduction. He is somebody everybody knows. He's been the Honorable Minister of Health in Nigeria since the current administration started. From what I understand, he's the longest serving one. He's a clinician by background. But Honorable Minister, welcome.
Thank you so much, Aliko, for inviting me. This is my second visit to Chatham House. But I must thank Rob for being a pillar of strength. Rob actually introduced me to the need to have UHC institutionalized in Nigeria. And he mentioned two things. One, that it has to be a political matter. And secondly, it's going to be tough. But you must never give up. So thank you, Rob, for sustaining me over the years. I think we are used to this slide. This is what we met in 2015. A country with little or no progress over the years in terms of the essentials in the health sector. And so we told ourselves, in addition to those programmatic challenges, we also had some non-programmatic challenges. We had to deal with allegations of fraud, particularly with respect to Gavi Fund and Global Fund utilization. And we lost the PR of practically all the three major projects. And so one of the things we had to do was to build trust. And then we also faced public health emergency. There was Lassa, so many things happening. In one particular village in Niger State, we lost 17 people, Fuka village, from Lassa fever, without anybody getting to know. And then we had to deal with fractionalization of the health sector. And then we used this man's name to address quite a number of things. And for my first year, 2 years, I kept on using his name. And the fact that he's fighting corruption, we had to put many things in order in the ministry. We had to restructure the Department of Health Planning, Research and Statistics. We had to work in National Primary Care Development Agency and so on, such that as of today, we have restored the PRship of the three major grants. And we've also won 1.03 billion from Gavi over the next 10 years as part of the restoration of confidence in the Nigerian system. Very early in the life of the administration, we also developed a blueprint. What exactly were we interested in doing over 4 years? We identified 4 priority areas. As a policy person, you do not have to focus on everything. You can't solve all the problems of Nigeria in 4 years. So we concentrated on maternal and neonatal mortality reduction. We concentrated on eliminating mother-to-child transmission of HIV. We concentrated on cancer because we met a policy in place where everybody that died outside the country, before you can bring the corpse in, the minister has to give a waiver. So through that, I created a database of all those who died outside Nigeria. And then I discovered that cancer happened to be the major reason why Nigerians die outside the country. So we thought we should address the question of cancer in Nigeria. And then the public health emergency. These happened to be our 4 signature projects during the life of the administration. But in order to address this, our experience in Niger State showed clearly that we need to restructure the health system. We had a health system with an inverted pyramid. The primary system had collapsed, the secondary was not functioning, the governors abandoned the healthcare system. And then everybody walked into a teaching hospital. This was not what it was when I was training. When I was training in usage, you cannot enter usage without a referral letter. You needed to be referred. If you entered without a referral, you'll be triaged in the family or outpatient department, and sometimes you have to go back to Adeoyo or somewhere else. And if it was an emergency, you'll be attended to in usage. That was the situation. So we thought that we needed to restructure this pyramid for us to achieve success. And we right away decided that we need to put a lot of emphasis on the primary care system. This is the story of the primary care system in Nigeria. It's not strange. We started the first PAC in the world in 1962. University of Ibadan started the Ibuara Community and Primary Care with support from the Rockefeller Foundation. This was in 1962. So we sold primary care to the world. And we made quite a number of attempts over the years. Under Ransom Kuti, we put life in primary care center, but one thing was lacking, the need for sustainability. When Professor Ita Olambo came on board, he also put life in PAC. But then there was also no sustainability. And so we knew right away that for PAC reform to succeed in Nigeria, we must have a system to put money in the PAC. And so clearly, we had agreement on what we needed to do. Sorry, something is stuck here. Okay, I'll use this. Yeah. I was actually using my system, but I think it's stuck. Ooh. Can someone help me out?
It's back, I think.
It's back. Okay.
It's back on that.
So we built on the foundation of the National Health Act, which we met in 2014. And what we did was to ensure that we got the Gazette out, and we considered that to be the foundation. And then the issue of the basic care provision came. I had no doubt in my mind that to me was a good platform to achieve UAC in Nigeria. But we had a problem convincing political leaders that it was necessary. At the last time, the Minister of Budget said, let's do a pilot, convince us that it can work. And thank God, Global Financing Facility of the World Bank gave us money. Bill and Melinda Gates Foundation gave us money to say, look, go and start. But then we must thank Senator Tejuosho, who facilitated it with his colleagues, and the Senate President, who ensured that we got this appropriated in 2018 for the first time. So that provided the resources for moving this forward. As of today, we have 22 states have signed on for this program, which we call UWE. UWE is an Ibira award in Nigeria for life. And as far as we are concerned, we thought this would bring life to Nigeria. And so we have UWE, and we are happy that Mr. President launched this January 8th, but we started the rollout last Friday in Osun State. So these are all the green states have agreed to participate in UWE, and we are quite sure that we will get to all of them pretty soon. And so this is the flag off. We're moving to Niger on Thursday, and we will visit Katsina and Abia, and then roll out to the remaining 22 states. In terms of programmatic success, I think there is the whole story of Nigeria that if the lizard drops from a treetop and looking around, and he has to celebrate himself. So I think we must also talk about what have we really achieved in terms of success over the last 4 years. Programmatically, we succeeded. When Nigeria rebased the economy in 2014, what should normally happen is that Gavi will phase us out. Gavi is a financing mechanism for getting cheap vaccines into the country. And Nigeria said, oh, we are no longer a poor country. And Gavi said, if you are no longer a poor country, we'll phase you out. But we knew we had challenges. So with all the reforms that we did, we paid back $5 million to Gavi as part of the money misapplied in the past. And we did a lot of reforms, we made promises, and Gavi has restored us back. We now have a 10-year transition program with Gavi. The first time any country in the world will get a 10-year transition. And that will also yield us $1.03 billion over 10 years, with Nigeria investing 1.9. we've been able to improve coverage on routine immunization from 48% to 57% in less than 1 year. For the first time in 2017, we decided to abandon the administrative coverage data that we were using for immunization. In Nigerian, in fact, we had administrative coverage 100%, 95%, 110% coverage. But everyone knew that if you have 80% coverage, there will be no outbreak. So for us to be having measles in somewhere, all these over there, meant that there was really poor coverage. And so we decided to abandon the administrative coverage and use mix. And we got to know that the coverage in Nigeria was 33%, not 100, not 110. Some states had coverage of 3%, 6% in some parts of the country. So we declared an emergency in routine immunization, and we've been doing quarterly reviews. So we've improved coverage to 57%. The NICE report indicated that HIV has dropped to 1.4%, emergency mother-to-child transmission down to about 0.3%, and we've improved contraceptive prevalence from 10% in 2013 to 18%. And we are hoping that when the result of the NDHS is released, we might be close to 20%. That to me will be so remarkable. The country will achieve a 10% increase in 5 years. So to me, that's the success story. We've also launched a diaspora program, we call it 11-1, where some of you here will be able to come home for 3 to 4 weeks, work with us, and we will deem it that you are employed for 1 month, but you're on leave for 11 months. So that will also help us to convert the brain drain to brain gain. And we're also working actively in 7 of our teaching hospitals to improve cancer care. Again, we have recorded some progress in malaria. We have dropped prevalence from 42% to 27%. We also have a Save 1 Million Life initiative where we have disbursed about $256 million to states as incentives. If a state is doing well, we'll give you some carrots so that we'll be able to increase you further. We also launched a national humanitarian health and nutrition response in the Northeast, where we have about 325 workers working in 25 of the 27 local governments. With polio, we are almost there. In the last 32 months, we not picked a case of white polio in Nigeria. And we must thank Mr. President, who in 2016, when we had the first outbreak in Northeast, from the security challenge area, he released 9.7 billion. The first time in the history of Nigeria that Nigeria will release the entire amount of money allocated for polio eradication. In the next year, we release 4.7 billion. And in 2019 budget, I'm here to see the details, I think we'll still have the same amount there. We also operationalized the Nigerian Center for Disease Control, which has enabled us to accurately predict, detect, and respond to health emergencies in Nigeria. What is also unique is that the Nigerian Center for Disease Control produces a weekly report that is tabled at the Federal Executive Council. So Mr. President knows every week what is happening all over the country with respect to public health emergencies. And we're also handling malnutrition in Nigeria. We're partnering with UNICEF, and the last 18 months, we've released 1.6 billion naira to UNICEF to handle acute malnutrition. And we also have a $332 million project with the World Bank, which we call Accelerating Results in Nutrition. We want to put nutrition behind the bars. In terms of tomorrow, because we must not only talk about the past or the last 4 years, we must also talk about what are we putting across for the next 4 years. One, we will want all these efforts to be consolidated. The partnership must be sustained. WHOE has to continue beyond 2019. The financing must be robust, and we want to thank all those who are involved in putting WHOE in shape to be able to do this. We also believe that we must put in place a robust mechanism for measuring impact. We need to move away from using input as a way to assess performance in that sector. We need to look at results. What has the $256 million, what has it achieved? What has the $232 million in nutrition, what has it done? And we believe that we're moving into 2019, 2020, we'll begin to see dramatic changes in the landscape of the Nigerian health sector. I think I'm going to stop here, but really thank you for your partnership, and to say that over the next 4 years, I'm sure things will change for the better in Nigeria. Thank you.
Do you want to sit here, or you want to see some of the slides? But you can join us here because. Yeah, we'll see the slides. Okay, that's all right. Thank you very much. Thank you very much. I know you have been thinking about questions, but please hold your questions. We'll come back to them when the panel session starts. The next speaker now is Senator Dr. Olariwaju Tojoshu. He's the chair of the Senate Health Committee, a medical doctor by background. He has an amazing passion for health, so he doesn't need no much introduction apart from that. Senator, we are welcome.
Good morning, distinguished guests, ladies and gentlemen. I thank Aliko, Rob, and the entire team of the Chatham House for inviting me yet again to present what we've been doing. I was there at the beginning, and this happens to be my last month as a practicing or current senator in Nigeria. So I thank God that I have a place to present my report. First of all, I want us to understand that the Senate is more difficult than the Ministry of Health in terms of taking decisions, because the minister has just the Minister of State to contend with. I have about 6 members of my committee that we are all equal in the committee. Today I have Senator Mao Nwabunwa, and he is chairman of the primary health and communicable diseases. I am chairman for the tertiary and the secondary. And I also have Senator Odia, who is my vice chairman for health. So I cannot take ownership of any success without the combination of all of us. So I just want that to be clear. And if I were the Minister for Health today, I would recommend them for honorary doctorate degrees, because they have been so good with our decision making. And without them, we wouldn't have achieved what we have achieved so far. So I thank them too. Of course, I also now realize the importance of the profession of who is heading the Ministry of Health. And I believe the little success we have achieved in Nigeria in the last 3 years is because of my beautiful relationship with the Honorable Minister, who is my senior colleague in the health profession, and also because of the profession of our president, the Senate president, who is also a medical practitioner. We could discuss intelligently and come to quick decisions. And I believe that is a major contributor to the achievement thus far. This is talking about the future, the next 4 years, so that the executives and, in fact, the system will benefit from such arrangements if we have such professionals in charge of our health sector. At the beginning of our tenure, Honorable Minister, I saw him as a very good person for me to work with, because he's very good at presenting what we are going to do for the year. And it made my life very easy, because all I had to do was to ensure I support him by appropriating adequately, and also to ensure that the recommendation given by African countries in 2001, when we had this Abuja Declaration, they recommended to all Africans that for you to have a successful health sector, your budget must be, for the health sector, must be at least 15%. And if you look at the chart that Rob gave us earlier, all the countries that achieved success so far, they are either near 15% or above 15%. So we don't need to reinvent the wheel. So we know that health financing is key for success for the health sector. Nigeria, that claims the ownership of the declaration, which is Abuja, unfortunately has not achieved up to 5% since 2001. And even the 5% is only on paper, because we have releases of not maximum 3%. So we can say maybe we've achieved 3% so far, ever since 2001, that we have declared this understanding amongst African countries. So we should, first of all, know that the basic of realizing the effective minimum health financing must first of all be achieved before we start talking about even corruption or how you spend the money, because we have not even achieved that health financing. So when we came in 2015, we realized that the low-hanging fruit was to achieve increase of the health budget. At least that should be the basic, first of all. Otherwise, we will just be going round and round and nothing will be achieved. And at this point also, I want to recognize the contribution of the Nigerian Institute for Legislative Studies. Professor Ladi, she's been very, very cooperative because she encouraged us by funding most of our trips to see how other African countries were doing. And myself and my colleagues, we've been to South Africa and so many other places just for us to come back home and know that we need to do more for the health sector. We now realize that for us to move forward, the first thing to do was let us try to implement this 2014 Health Act, wherein it is stated that at least 1% of the consolidated revenue fund of the country must be dedicated to the health sector. And looking at that, it is also supposed to be a statutory transfer, which means that it must be released. It will go into that fund as stipulated. So myself and my colleagues decided to pursue that. In 2016, 2017, it was very tough. And we successfully achieved that in the 2018 budget. This was equivalent to about 55 billion naira, about $180 million at that time. That's 2018. And thankfully, again, it is also appropriated in 2019. So I believe the ministry did not expect us to succeed, because I realized that most of the states were not ready for this money. Because one of the conditions for enjoying that money was that each state of the country must have a functional national health insurance agency, must also have a primary health care agency for them to be able to access that fund. But unfortunately, I would say maybe only 50% of the states are ready as of last month. So the money is there now, and they need to hurry, quickly put up their agencies to benefit. So, which is also something that, we need to work on very, very quickly. With this fund, our primary health centers will now receive their own allocation directly from the central bank. There will be no bureaucracy for getting this fund. Of course, it will be monitored by the Ministry of Health. The Ministry of Health, they've presented a very good guideline on how to appropriate this money, how to spend it. And I believe if this is implemented fully, Nigeria will be the better for it. As of today, our tertiary institutions, the teaching hospitals, they are behaving like primary health centers, because that is where the Honorable Minister that for us to move forward, they must give instructions to the medical directors of the teaching hospitals to stop behaving like primary health centers. They should refer all the patients back to the primary health centers, because we have over 30,000 primary health centers in Nigeria, but I would say maybe about 4,000 is functional. And the people, they don't have confidence in our primary health centers. So, but now with this injection of funds, I believe that we are now going to make the place more functional. And the industrial action that we are known for in the sector, I believe once these primary health centers are now functional, we will not even notice all the strikes in the tertiary hospitals anymore, because the primary health centers, they will be readily available for all Nigerians to receive the basic health care. And the funding that we are giving the primary health centers will also make our health workers more ready to go to the rural areas to work, because they know that every month their money is guaranteed. So this 1%, which is supposed to be a minimum, is going to be a game changer for the health sector. And I know my colleagues from this next month, they will ensure that 1% is increased to 2% at least. I will still be troubling them from outside to ensure that We have progress, and we don't stop where we are. Again, one of the problems we've been having in the health sector, I'm trying to focus on things for the future that we need to do, learning from my experience. Another problem we have in the health sector is that of double budgeting. The state governments don't know what the federal government is budgeting for. So you can have maybe Sokoto State budgeting for one cancer machine. At the same time, Federal Ministry of Health is also budgeting for cancer machine in the same location. We say we don't have money, but yet we are duplicating efforts. And this is because the states don't talk, the state legislators don't talk to the federal legislators. So because of that, in 2017, we introduced what we call the legislative network. All the chairmen of all the health committees of all the states and the Federal Capital Territory, and then the health committees in the Senate and also the House of Representatives, the chairmen, all the clerks of all these committees, the speakers of all the houses in all the states. Then we call the chairman of the appropriation committees of all the states and also the National Assembly. So we came together as a committee. We called ourselves the Legislative Network, for us to compare notes, to encourage ourselves, to know what we are doing in the states so that we do not duplicate, and also to compare the states and let us have a kind of competitive relationship. And we've had 2 meetings so far, and I believe it also contributed to the success of this 2014 Act that we achieved. And the 2014 Act is really a good Bible for moving Nigeria forward in the health sector, because it has so many good things. But of course, we concentrated first on the money aspect, which I believe we have achieved now. But it has the issue of every health institution must have the capacity to capture data, so that we want to know how many people had malaria in Nigeria this year. We don't have to go to WHO. We should be able to go to our own institution in Nigeria to educate us on how many people have malaria in the country. And we have so many other areas of, the standards of the hospitals. Every 2 years, they must be inspected and given their certificates, so that Nigerians, when they go to any institution in Nigeria, if they don't see that certificate there, they will not patronize such places. Also, this year, of course, with the cooperation of the minister again for 2019, we realized that we need to move away from funding infrastructure all the time. Because for the past maybe about 5, 6 governments, we've been trying to fund cancer machines in Nigeria. But I would say maybe as of today, for a population of over 180 million, we have only about 10 machines working in the country, which is definitely not enough. Honorable Minister told us earlier that most of the people that die abroad, they die from cancer. So Minister and myself, we discussed and we agreed that we should set aside some funds to pay for patients that have cancer. Because today, if you go to any bank and you say you want to set up a cancer center, the banks will not support you. They believe that health businesses are not commercially viable. So we're having a lot of problems. But of course, the most successful health business in Nigeria today is the one set up by foreigners, Indians. We have a company called Secure. They have set up many diagnostic centers all over the country, and they're doing very well. And most of us that go abroad for ordinary laboratory tests, investigations, now we are confident to go to Secure because they invested heavily in Nigeria. So we now said, okay, with this appropriation that we did in 2019, we now have about, I think about 1.5 billion to pay for services for cancer, for maybe kidney problems and so on like that, for Nigerians. And also to ensure that people can now go to the bank and say, look, we want to access this funding from the ministry, but we don't have the equipment. The banks, once they see the money that's available, they will now fund our Nigerians to set up such centers. So I believe it's a good beginning, and my colleagues will continue to support the Ministry of Health to ensure that we keep on going forward like we've started. And then again, we decided also to amend the National Health Insurance Act because funding is key, as I said earlier. And we have the population on our side, and little contribution from Nigerians, as low as $1 per month, will make a big difference in our health financing. So we decided to make health contribution mandatory for every Nigerian, which is now in a new law that we passed in the Senate, which we hope within the next 2 weeks, Mr. President will assent to. This means that Nigerians will now contribute something to the health fund every month. But of course, it's not for everybody. Not everybody can afford that, we know. So at least we are expecting at least 100 million Nigerians to pay at least $1 every month, which is about $100 million every month, which is more, at the end of the year, is more than the budget of health maybe in 4 years. And I believe that will also help Nigeria to get successes in the health sector. This, of course, again, the major aspect that we need to consider very well for the next 4 years are the people running our various health sectors, the NHIS, the primary health care agency, and so on. Because if we don't have cooperation at the top, there's no way. We can have all the beautiful ideas, we can have all the money, but things will not move. So the executives must ensure that they put the round pegs in round holes. And also, I believe also the interpersonal relationship of the people at the top is also very, very key. Because I don't want to be specific, but I believe interpersonal relationships has cost us a lot of problems at the top. And Nigerians are the ones suffering for it. And I'm sure if I'm outside the Senate, I'll be able to talk more. I'll talk about my experience, and I know we have a lot of work to do. So I'm looking forward to my life after the Senate, and you'll hear more from me. And I'm very hopeful that what we have started, the foundation we have laid, we shall definitely get to the promised land. Thank you very much.
Thank you very much, Senator. I think this has worked beautifully in terms of time. Although we miss Nduka, but I think there will be a lot of time for discussion now. You are ready for your questions, and what I will do now is to invite colleagues to be on the table. Honorable Minister, please, if you can join us. Senator, if we can join us, and Rob, if you can join us, please. And then I will introduce my two good colleagues. Professor Ladi Hamalai, she's the Director General of the Nigerian Institute of Legislative and Democratic Studies, please. And then Professor Hadiza Galadanchi, she is a clinician and academician. She's the Director of the World Bank-supported Center for Excellence in Population Health and Policy. Thank you. Have a seat. They can have that one, Rob. Well, thank you very much, everyone. This is, I think, one of the fun bits. We've had a lot. We've had a lot of discussions. And Ngozi and Alex are quite happy to take some of your questions, but what I intend to do is to ask them a few questions and then come over to you. So we can do it almost like a kind of audience participatory approach to that. And if I may just start, we had a lot, certainly from Rob, around the value of political economy and how that is successful around that. And I'm sure many of you are probably aware of this interesting study that has just been published recently in the Lancet around democracy and health. What that shows was that they compare countries that are quite democratic and those that are not. What it shows is that countries that have been democratic have had a rapid increase in terms of their life expectancy, in terms of their heart health, number of cases of diseases averted, and death. What that essentially is saying, democracy is good for your heart and is good for your health. I just wanted maybe to start with you, Professor Hamalai, because you've been quite good in terms of studying democracy and legislation in Nigeria. What's your kind of sense of maturity of democracy in Nigeria and its responsiveness to the people's need?
Yeah, thank you so much. Democracy is simply accountability, actually, to the electorate, to the voters. And I believe that the reason why there's a positive relationship between deepening of democracy and improved health systems is because of this factor of accountability. If you bring this to Nigeria in particular, you could discover that between 1999 to date, there has been tremendous improvements in provision of infrastructure in the health sector. I think the most important is the constituency projects and the zonal intervention funds in the budget. The legislators feel that they must be impactful in their constituency, and as a result of that, the legislators have been able to achieve a very good development, which is a certain portion of the budget is allocated to legislators to inform the executive of the primary projects they want in their respective communities, constituencies, senatorial districts. And a lot of those really are health-related, health centers and so on. And the Honorable Minister, in fact, mentioned that there are thousands of them. And it's as a result of that. Many legislators on their part also, using private resources, normally provides certain facilities to their constituents. During campaign, after campaign, some even give out a certain percentage of their resources to their constituencies based on agreements. So a lot has been going on in that direction. And this second is oversight. Legislative oversight has been key to the development of health in Nigeria. I could remember some time, I think in the 4th Assembly or the 5th, where the Health Committee went round the Senate. Health Committee went round the whole of Nigeria, all the teaching hospitals. They were able to itemize some of the basic difficulties and challenges in the teaching hospitals, including industrial action. By the time they converted their report into a House resolution, Senate resolution, they met with, I think at that time, President Obasanjo, and begged him to take care of the teaching hospitals. And lo and behold, he accepted that. And all the teaching hospitals were built for upgrade. And I think a lot of work went into teaching hospitals because of that oversight. And I could also remember that most of the time you find that the Senate committee increased some of the budgets to settle some of the industrial activities, actions by doctor strikes, whatever their arrears of payments are. They've been able to do that almost every budget. So you can see a direct relationship really between democracy and health. But before you stop me, there's one more issue. Believe me, there's also a downside for that. Yeah. From 1999, incessant strikes, I think you started mentioning it, by doctors, became a national embarrassment. We did some research on that and discovered that up to 2014, there are about 60 strikes, industrial actions, some warnings, some lasting even months. And if you look at the impact on access to health, we are told that there's an inverse pyramid, the health sector, where teaching hospitals become primary providers. The teaching hospitals alone, mostly 500 to 900 beds. If they are on strike, if the doctors are on strike, per day, you discover that 23,500 patients who need intensive care are shut out per day. They have to go to private hospitals. Many die in the process. So we still don't understand why Nigerian doctors have made it their, what do you call it? I mean, a major issue, any small issue, they have to go on strike. It's as if it's a pastime for them to go on strike.
Okay, bro.
So sorry.
I think two things. What I'm hearing from you is that there has been a bit more accountability from that, but the issue of doctor strike, I think, will be quite adequately addressed, especially that we have Professor Galadanchi here. What I noticed, and I'm sure many Nigerians have noticed, we just concluded the election in Nigeria. And throughout the debate and the campaign period, I don't think I've seen anything about health at all. In terms of any political party, there was almost silence about health completely from both the members of the public and from the professional groups. One may suggest perhaps it's either it's a lack of awareness or less engagement, but what is that professional lines now? Is there a kind of mechanism by which the professionals, i.e. doctors and others, are engaged very much with the democratic leaders? And if you can address some of the perhaps underlying causes of the strikes that Professor Hamalai has said. Professor Galadanchi.
Okay, thank you very much, Professor Aliko. I think one key thing is that there is a real gap between the professionals, the academia, and the policymakers. For example, we know that translating research into policy, into strategies, into innovations is key to sustainable development in whichever area you take of sustainable development, including health. So if the policymakers are there, they lack the time, the resources to look at evidence, to look at clear results that can influence their strategies in terms of policy decisions. And then the academia and the professionals are in their ivory towers, seeing patients and doing clinical research without actually looking at what is driving their research. Are they really doing research to answer the questions that the policymakers can utilize in order to have, policies based on decision and based on real evidence? Because policy should be driven by clear, proven evidence, and that can be obtained from research. But then there is this gap, a major gap. So somehow we need to, bridge the gap. For example, now, in one of our hospitals, in one of our teaching universities, we have over 1,500 academic personnel. They publish over 700 peer-reviewed, papers in peer-reviewed journals. In fact, there is an article that says in 2012, we had over 3,600 and about 80 publications from Nigeria, just second to South Africa. But most of the publications are not really being utilized by the policymakers to influence policy. So they are mainly used for promotion. Now, for example, the basic healthcare fund that we've been talking about, I read a paper that was, presented by a research group in Nigeria. And they actually developed a framework on how it can be implemented. Now, the honorable senator said, that now the money is available, but then what about implementation? And that's the problem of Nigeria. There is no policy that we don't have that is the best in the world, that others copy, but then we don't get to really implementing it. And that's where the challenge is. But this research group actually brought out a framework. They explained exactly a framework of accountability and governance on how you can implement basic healthcare provision fund, explaining the various ways you can get the 1% consolidated revenue, how it can be utilized, the roles and the responsibility of the federal level, the state level, the local level, and even the primary healthcare level. What are they supposed to do? And all we need is really to get this framework and actually implement it. That means research has helped in implementing basic healthcare development fund. So what we have decided, seeing this as we're saying, we're not talking about issues, we're talking about solutions. We have decided, like in Nigeria, in Kano, to establish a center. We call it an African Center of Population Health and Policy, which is a World Bank supported center, where we're focusing on how we can achieve sustainable development, mainly SDG 3 in Africa, by training manpower, postgraduate students, training them in skills that they can do research that can actually be translated to policy. First of all, their research should be driven by what is the problem? What are the issues? For example, how can we get this basic healthcare provision fund, implemented? What are the challenges? And then they do research to find the answers. And these answers can now be utilized by our policymakers to now move the agenda forward. But as far as we are on one side, the academicians and the professionals, and then the policymakers are on the other side, then we're going to have problems. The senators said we need to look at results. Now, researchers should be able to give you results. When you go and roll out a program, then you get researchers to tell you what is happening in the grassroots. And then you can now say, okay, this is working, this is not working, and this is how we're going to move.
So, Professor Galachi, that's really helpful. So what you are saying now is that there is an attempt to try and reduce that gap between the researchers and the policymakers. Because you can have all the excellent research done in academic institutions and have degenerated knowledge. The policymakers here need that knowledge. But if there isn't any mechanism of looking and discussing with that, then they wouldn't know. So I think the issue is not probably just the politicians as well, it's also the researchers. There has to be proactive approach and finding ways to perhaps find that dialogue. But that's good. Let me move onwards, except if anybody wants to, because I have other questions now that I think are quite helpful. I referred to that study about democracy and health. And one of the things that came out of that also is sort of how it affects sort of clear health outcomes, so reductions in sort of death from heart diseases and many others. And the minister has touched quite in a number of programmatic successes. Minister, do you think democracy has been good to Nigerian health?
Thank you, Aliko, for that teaser. Because I'm conflicted, I will certainly not be there if there is no democratic practice in Nigeria. So the straightforward answer will be yes. But there are challenges. Some of these challenges will be overcome as we have better networking between the legislature and the executive, between academia and the community. Because for you to have people turning out policy documents that are not accessible to us, we won't make the desired progress. So it is important that we bridge the gap. And the gap has to be bridged in all sectors. And we also need to document successes. I think essentially Nigeria is a talking society. We don't put much into writing. So it is important that we document our success stories. It's also important that the governed should also challenge those who govern them and frame the questions. You did mention that during the process of the last election, I don't think it is absolutely correct that health did not feature. Health featured. If you read the next level document of Mr. President, health was there. And I can assure you by May 29, health is also going to be there. In fact, Mr. President has consistently promised that in his second term, he would devote more resources and attention to health and education. So, with respect to the democratic experience in Nigeria, we are going to see what I would call a turn around for the better. We are also happy that the main driver of investment in infrastructure, the World Bank, has also done a U-turn. At the World Summit on UHC, the former World Bank president apologized to leaders in Africa and developing countries because the World Bank happened to be the major promoter of infrastructural development. Now, the same World Bank now said, for us to invest and fund you for infrastructure, we want to see what you are doing with human capital. So we think with that change in posture of World Bank, a renewed attention at country level, we will see a deepening of investment in human capital, and the entire continent will benefit. And then there is need to do some shift in expenditure. We're spending too much on wars and buying weapons, and we need to do more on the human resources that we have.
So I'll pick on that one. That's a nice segue into sort of the issues about health financing, because if we have to achieve USC, two key pillars have to be addressed. Coverage is one, but financing is important. I'll bring Rob in a bit, but let me go to the senator first. Nigeria, when you look at all the sort of intentions and the beautiful documents and strategies which we have, starting from the Nigeria Health Act of 2014, Nigeria National Health Policy in 2016, and many more, there has always been that intention to try and provide basic health services to all Nigerians at affordable cost. You have the Nigerian health insurance scheme that has been implemented now over a decade. But when you look at the coverage, it's still less than 10% of the population, the last we checked. But you've talked about progress, Senator. What has happened around trying to make this change and get to the ultimate intention of ensuring coverage at affordable cost to all Nigerians?
Well, first of all, we have to look at what we had in the past, immediate past. The National Health Insurance Scheme, they were saddled with the responsibility of expanding the reach of health insurance in Nigeria. But you know, the team handling the scheme, they changed their focus. Instead of being just the regulators that they are supposed to be, they wanted to also be the team to implement the services. So once that happens, then there's no way they can grow the population of insured Nigerians. So like I said earlier, the people that are going to implement is key. Because all these policies, they are good on paper, but it's just to get the right people to implement. So that's that. But now that we have introduced this new law, once Mr. President assents to it, and all Nigerians are contributing, they will expect to have something for their contribution. They must expect that when they go to any primary health center, they can have functional service. And I have to divert a bit. You said politicians don't talk about health. Yes, because we know the people don't believe. Because all the politicians before us, I think the low-hanging fruit for people is their health. So they've been talking about, when I get there, I'm going to change things. So that is why today you will see that most politicians, the first thing they look for is, please, I want a primary health center in my community. They don't, I mean, we don't, because unless you're a medical doctor to know the basics, to know what you need for that. That's why today, if you go to any campaign ground and you talk about you are going to provide any health service, the people you are talking to, they will remember that there is one primary health center just in their backyard, but it's now like a poultry farm. We have too many infrastructures in the name of a politician that we build this, during my time, I built this primary health center. But we don't communicate with the Ministry of Health to know if they are ready to staff it. They don't have the capacity to run all these health centers that we are building. So we spend so much money on infrastructure, and we don't allocate money for the services to be rendered in the health centers. So that is a major issue, but that is why advocacy must continue, even with our legislators, to let them know the importance of this spending and the irrelevance of just having infrastructures that we cannot manage.
So that's helpful, Senator, and I think in terms of...
Just a minute.
Okay.
I think what is very key, as you have said, Senator, is right now the Basic Healthcare Provision Fund. We really don't have the manpower, the capacity, and the ability to use that money at that primary healthcare level. I mean, at the local level. That would be a major challenge. So somehow,
I have a question on manpower, but I have a question on manpower. Let me keep on this finance. Let me Honorable Minister, let me hold on the finance.
Well, let me just say that it's wrong.
Okay.
That's the attitude of a doctor practicing in a teaching hospital. We are far removed from where things are happening. And we think that what we need is a highfalutin theater, all the surgeons in this world to run a primary care center. That is not right. In fact, what we are doing is actually building capacity, training them, and they are doing excellent job. That's why we are doing the rollout.
I think this is a good one. I'll come back to that because the senator had actually touched on the issues about how teaching hospitals are behaving like primary health care. I think we'll come back to that question. Let me keep to the finance one because I think the senator made quite clear that it's the issues about efficient use of the resources that we currently have. But going to what, to Rob now, when you look at all the indices of health finance, and whether it's the total health expenditure as a proportion of GDP, public health spending as a proportion of GDP, in the Nigerian context, it's been quite consistently low. And from what you are saying, there is a correlation between that and the attainment of UHC. So where do you think we are now if the focus is more around continuing where we are or the national health insurance as you understand it that the senator had described?
Sure, thanks, Erika. And I think it is absolutely the case that the prerequisites for universal health coverage are genuine political commitment from the head of state and public financing. And I also work for a group called the Elders, who are sort of former world leaders, many of whom have introduced UHC reforms in their own countries, and they're basically agreed on this. And you might say that the barometer as to whether there is genuine political commitment is the level of public financing, and you know, are people putting their money where their mouth is? And you know, objectively, you have to say that with a 0.47% GDP public health spend in Nigeria, that historically, that hasn't been the case in Nigeria. You know, there hasn't been that sort of commitment by the head of state. Maybe one or two state governors have sort of gone ahead a bit and put more public financing in. But at that national level, you haven't seen that big increase of public financing. The encouraging thing is, though, that you do see right around the world that countries go from that low level to suddenly take off. That, you know, this isn't sort of a slow process that you add on 0.1, and you grow slowly. All around the world, Thailand in 2001, South Korea in 77, Australia 71, us in the UK in 1948. You suddenly see it take off. And that really is where a presidential candidate or a political party says, enough now. We are going to socialize the health financing system. We are going to introduce a compulsory system, either through compulsory social health insurance or through general taxation, or these days tending to mix the two. This is what South Africa is going to do as well. And I'm confident that at some point in the next 30 years, that will happen in Nigeria. And you'll be able to name the politician and the year that it happened. You know, you'll be able to add to that list. Now, will that be Buhari in 2020, for example? You know, we don't know. It would be great if he did. If it's not going to be the current president, maybe there are presidential candidates in, you know, further down the line who might be interested in doing this. But I think what we in the health sector need to do is to be thinking, how do we pitch this to those leaders that they take that monumental decision to do that? And maybe what we should be doing is selling the political benefits of that more so than the health and the economic benefits. Because at the end of the day, politicians want power. They want power to be able to stay in government and to do lots of things. So if we can package up the benefits of UHC, sure, you know, it's going to improve health indicators and reduce inequalities. It will lead to improved long-term economic growth. But the best sell to politicians is this is their route to power and to stay in power. And that would be very much my recommendation in engaging with politicians, that we go route one and say that UHC brings votes, brings power, and you can become a national hero.
And as indicated, Ngozi showed us the indication that the president said health is a human right in Nigeria. So I think that's a good start for a politician. Professor Hamala, before I bring you, let me open it a bit to audiences around. You can see hands flowing around. Ngozi, do you want to let's start from the lady there. Oh, you can introduce yourself. I know you, but you can introduce yourself to other people.
My name is Titi Banjoko. Just two key points. First of all, politics is health in terms of, and even here in the NHS, it is massively political and massively regulated. But I think the question really is how in the UK, as an example, the question is not where the money comes, is what we use the money for. Yeah. Because everybody knows not everything is free in the NHS. I always tell people we do have things we do not fund in the NHS. So it would be good to be clear about what sits in that universal health bucket in Nigeria. Then the second thing I wanted to say in terms of accountability. So one of the things I find myself out doing here under Chatham House rules, I'll say, is as a managing director somewhere in the UK, I am regularly summoned by local councillors to come and talk through issues. It is the Health and Overview Scrutiny Committee, those who know about it. And anybody can be called. Secondary care, tertiary care, the ambulance service. That is done in public with members of the public. So you're taking care closer to the population. They understand what their rights are. They understand what the issues are. And that begins to improve the accountability at every level. At the moment, a lot of things are probably done at federal level and secondary level. If you ask local councillors who are closer to the public that they serve, do they summon, even private health sector, do they summon them on issues that they're members of their public, and we'll call them town halls? And I would suggest that as a solution in Nigeria, because that begins to inform the public so that they begin to understand what their rights are. Yeah. They begin to understand the information available to them, and then, like you said, Rob, then maybe when voting comes, you don't even need to tell them, because you can't lie if you've had a town hall meeting and you have come up with statements, and then when it's time to vote. So, and then the final point is, it would be good to understand what the minister referred to as the diaspora program, because many of us here would definitely want to engage in that.
Excellent. So, point of reflection, because we will take another question. Professor Hamalai, I think the issues of accountability, we'll need to discuss that. Senator, I think you touched about the legislative network and this idea of scrutiny. Do you have a regular program where you bring people who are responsible for delivering certain responsibility on behalf to be scrutinized? That sort of will be back. Next question. All right, I'll come that way, I promise you. Professor Rotimi.
Good morning. Rotimi Jayes is the name. I think talking about working in silos, what I haven't heard this morning, when you look at education, poverty, literacy, gender equality, is the Sustainable Development Goals. And we do know that the universal healthcare coverage, target 3.8, will drive the SDG. Nigeria did not meet the MDGs, perhaps because we didn't come together like you've all said this morning. What are we doing as politicians, legislators, to talk about the SDG in relation to universal health coverage, or using universal health coverage to drive the SDG goals?
Excellent.
Thank you.
So again, another question, probably Minister will take this one. It's the beauty of what SDG does that is different from MDG, which is the intersectionality, the issues of working as a system. So Minister will want to get some reflection around how does health work with others to look at health as a whole, not just as diseases. I will take one more questions and then go there. I will start with him here.
Thank you very much. I'm Tosin Ajala. I'm a clinician, obstetrician, and gynecologist. I wanted to make a comment, first of all. I think I was speaking to somebody today, and I said when I started my training here about 20 years ago, one of my consultants then told me that the most two wasteful countries in the world are Nigeria and Pakistan. I said, why? He said, because it's unbelievable the manpower that you have and how wasteful you are with your manpower. So it does. I find it a bit surprising that at a primary care level, we cannot, right, facilitate those places. As a clinical director in this country, I have consistently been able to recruit Nigerians through the MTI, whatever that you know, right? And not one of them. Nigerians are actually quite good when it comes to delivering. The problem is how much is our problem, because these are intelligent people sitting down, right? How much is our problem cultural? How much is it us not doing what we want to do? Doctors will go from England, go to States, and go to whatever to show a guy how to do a laparoscopy. In 2-3 months' time, he'll show you how to do it better in Nigeria. That's the kind of people we are. Thank you very much.
So thank you. That's a good comment. And again, it reflects what Ngozi told us about one of the purpose of this session is to look at the contextual realities in countries. And that reflects culture, social dynamics, economics, and intelligence. Because there's no doubt about human capital in Nigeria and the intelligence potential. You just need to look everywhere in the world to see that. Why is that not being harnessed and optimized for the country? So I'll come back to one round of questions, I promise. But let's start with the accountability question then. Professor Hamalai, do we have a system of accountability where people feel that the politicians are doing what they promised to do? And what are the consequences for inaction?
Thank you so much for that question. I've read some research reports that actually conclude that politicians are over-accountable. They are too accountable. Yeah. This is a serious research.
You can follow with your reiteration. Let her finish her point.
This is a research report presented at Roxton College in Oxford here. And I could see it. What do you mean by too much accountability? Every politician has to go back home, has to give money, has to build clinics, boreholes, give generators out, and health issues. You cannot imagine how much each politician has been given to his constituents from his pocket to pay medical bills. It's huge, personal resources. So as for accountability, I think our politicians are just too accountable. The weight is so much on them that I believe that we need something, we need to reform the system in such a way that politicians will have more time to do their work, legislative work and other work, rather than handling personal demands from constituencies. So I think this is important. And there's no politician that is not interested in health. There's no politician that is not interested in funding health. But if you look at some of our economies, look at the poverty rates in our countries. If you look at Nigeria, for example, from 2015, we've been battling with insecurity. The very few health centers we have are being destroyed by Boko Haram. The whole of the Northeast is in a huge mess, health-wise, because of the insecurity situation. The economy has been in recession, out of recession, but it's still not stable. So where are you going to get even some of the resources that we are talking about? So it's not as if the resources are there and you refuse to just allocate 15%. No, I think it's beyond that. So we have to focus on repairing our economies, providing security, creating a stable environment for development to occur.
So that's helpful. I think colleagues probably around the table will come up with some comment at the point around how over-accountable politicians are. We'll come to that. I'm sure there will be some comment. Let me pick on this other issue because I think the legislative network, my understanding of it, is one of the innovative way of engaging legislators with health that has been pioneered in Nigeria. And Dr. Banjoko asked this question around, do we have a system whereby you hold people accountable from your health committee, where if you feel a teaching hospital or a ministry or something, you can summon them in to sort of be accountable for the actions of which they are intended to deliver? What sort of mechanisms do we have for that, both at federal and at your state level of legislative networks?
One of our cardinal responsibilities is that of doing oversight of all these institutions. We appropriate money to them, and we expect to go back there and see what they have done with the money. But unfortunately, the local council in the UK, they are so confident to summon different institutions to come and account for whatever petition that is written to them, because they have funded them, because they know that they should not be in a position not to deliver. But unfortunately for us, in the last few years now, or months, because we have not really funded these institutions, we have already appropriated money in the budget, but they haven't received the money. So when we go there, they will now be questioning us that, what do they want, what do we want them to do? When we have not paid for them, maybe someone wrote a petition that you got there was no water. Meanwhile, in the budget, we have already put down money for them to have a borehole, but they haven't received the money. So we know the answers now, and we believe that the next 4 years should be better if all what we have done now, if we implement them, that they actually get funded, and they have no reason to give excuses for failure. But as of now, we are in that transition period that we too are just trying to build them, make them confident to deliver to the public.
In addition, I think, to the resources issues, it seems what is coming around in terms of confidence is also the level of awareness and understanding of the right questions to perhaps ask. I think I remember you mentioning this is something that you want to sort of, if you like, scale across all legislative networks so that people are confident enough to know they can ask the right questions about health, about universal health coverage, about whatever is needed. Is that still the intention, or has that changed?
Well, I mean, the legislative network is to enable the legislators to really know the general problems of the country. Okay, for example, the legislator in Kano State, for example, they will think, oh, maybe the first thing they should do is to build a primary health center or something like that. But we are saying, okay, let us even concentrate just on water for everybody.
Exactly.
This year, let all of us make sure all our health centers, they have water. Let us appropriate on water this year. Okay, that communication amongst us will be able to change the way we do budgeting.
Okay.
So I believe the legislative network is a key for progress for the legislators in terms of appropriating.
And what we hope is your new replacement, hopefully the new Senate chair that will be coming, since you said you are taking a break, will be quite a good colleagues to engage with, and we can certainly see what we can all do collectively to improve that awareness and understanding among legislators. Minister, intersectorality, I think Professor Rotimi asked about what have we done to break down this barrier of health is just about disease and provision of services, not.
I think the beauty of the Basic Care Provision Fund, which you call UWE. UWE is an IBIR award for life. We did some crowdsourcing, and we chose UWE. It's because we're going beyond the concept of diseases. We are looking at prevention. And then we're also partnering with line ministries of water, environment, education, because these are quite critical. Even women affairs. in order to address some critical challenges that we're facing. The real beauty of the SDG agenda is the networking beyond health, looking at prevention, and how girl child education, poverty alleviation, addressing hunger will improve the status of every country. So I think we are quite really on spot with this. But let me just steal the opportunity to address two quick questions. One, on the minimum package of care. What we have for now is not enough to take care of all that we would love to take care of. So the Act empowers the minister to determine what the minimum package of care will be. And for the basis of the MPR, Basic Care Provision Fund, we're taking maternity care, including payment for cesarean section. We're taking under 5 ailments, including immunization. We're taking family planning as part of it. We're looking at malaria, which is our #1 challenge, and we're also looking at screening for hypertension and diabetes. So we're starting with this. And then we will then handle acute malnutrition and also give education, knowledge and training to mothers about breastfeeding and how to prevent malnutrition. So for now, these are. And let me also quickly turn left. The Basic Care Provision Fund is not too new. We started what we call an NSHIP project, the Nigerian State Investment Project, in 3 states of Adamawa, Nasarawa, and Ondo State. With World Bank money, we added 5 additional states. And what did we do? We wanted to demonstrate that what is critically important at PAC level is giving them money. Unfortunately, the Director of Planning is here, Dr. Meribole, the PAMSEC is here, they will be our testimony. This is a pilot project where we operated 3 financing models. One, we call it direct financing facility. We give money to the PAC every month. The second one is called the performance-based financing. We give you a basic. When you do well, we give you a top-up. And the third one, we call it business as usual. And when we went around to look at the performance of both the PBF and the DFF were quite comparable in terms of outcome. But the business as usual, you visit a primary care center, there will be no chair, no bed, there are no drugs, because there was no funding to them. And that's how we grew this system. To say, look, if that worked, let us now give them money directly. And giving them money directly will ensure that they can improve, they can buy bulbs, they can make sure the taps are running, and then they can buy commodities and give incentives to the staff. So 3 things. 15% of the money is for infrastructure, 20% for commodities, and 10% for human resources. And we have a manual, 130-page document that we spent 1 year developing, which is also available on the website of the ministry.
Thank
you,
So
it's important for the policy to look at this and then advise us.
Absolutely.
We'll take advice.
I think because of running time, there are 2 key questions I think I will need to raise, and I'll come back to you because I think you touch on that, Minister. Every health system relies solely, the #1 thing is about the workforce, the health workforce. And Nigeria, by all level of evidence we know, is suffering from chronic shortages of healthcare workers, doctors, nurses, and co. But we recently had one of your colleagues, I think, and you said actually you have a surplus. Is that a government view or is that a personal view of that? Honorable Minister, this is to you.
I used to think that you are my friend. Now I know you are actually taking me to let me say up front that if you work at the federal level, you might actually be frustrated. And I want to be open with you. What we are seeing in Nigeria is a system where everything now has left at the mercy of federal. Nothing is happening at the state level. And that has created significant frustration. If you ask me, my greatest frustration as a minister is because the states do not see health as important. Same for education. When the people tell you there are 13.5 million school children out of school, they are not federal students, they are states. Primary education is the responsibility of state. the state should put them in primary schools. Same for primary care. It's not our responsibility. But if we fail to tackle it, they will rush to the teaching hospitals and medical. That's why we're handling it. It's not our direct responsibility, but we're taking it on. The problem with human resources is that about 70% of our doctors, let me just use doctors, are concentrated in Abuja and Lagos. That's all. And then they are all in the federal institutions. About 80 to 85% of our budget is personnel. And let me go further. I will use CH and Oyo as an example, and use Zamfara and Adamawa. In usage alone, there are 325 consultants. At the state level, there are only 25 because the states will not pay them. The consultant at Oyo or Oyo State has a little more than a house officer in usage, so nobody wants to go there. And usage will tell you, if you ask me, I'll say usage, we're overstaffed. We don't need more doctors. We have enough. In fact, what we need to do is make them do more work. In my department of Ops and Gynae, I will use as an example, 22 consultants. We deliver 2,000 women a year.
So, Minister, clear.
So, let me just finish. You get to Zamfara State, there are 122 doctors in the Federal Medical Center. When you visit the state, there were 22 doctors covering 24 hospitals in Zamfara State. In Adamawa, I stopped in Jida, and I enter into a general hospital. Only one doctor. And yet the FMC Yola, owned by federal government, over 200. Yeah. So it's the problem of the state. So if you, at the federal level, you say, oh, we are overstaffed, and people might misinterpret it. It's the typical story of the Yoruba man saying the calabash is heavier than the porcelain pot. But what he should have said is that the dry calabash or the wet calabash is heavier. And that's correct. But the dry calabash is lighter. So at federal level, we're overstaffed. Too many people. But at state, nobody.
I think, Minister, many people recognize that Nigeria is a federal republic. You have the federal, state, and that.
That is on the exclusive.
But remuneration and retention is an important element of every healthcare system. Particularly, we talked about quality here. Is there no drive for a harmonized salary structure? And I must refer to a question here where someone said, ask them, why are there big differentials between legislative income and doctors' income or nurses' income in the country? Perhaps, Senator, you might say something about that.
Fortunately, there are 3 senators here and an honorable member of the House of Rep. We do not know how much they earn. So I think he is most competent to handle that. But I will tell you that if you ask me today, I will tell you our healthcare professionals are underpaid. We need to give them incentives.
But that is the drive for the harmonized salary.
In India, you are not only well paid, you are sponsored to attend 2 overseas conferences every year and 4 conferences within the country. And that's why when you go to international meetings, you find Indians. They are supported. You are given free accommodation. So we need to build incentives.
So let's, Senator, maybe
over to the distinguished senator.
Yeah, maybe we pick about how do we address these underpaid issues then for the healthcare workers and ensure that we are retaining them and keeping them where they should be to improve the quality of health in the country?
I believe it's very simple. The government of Nigeria is separated into 3 arms. We have the executives, we have the judiciary, and we have the legislature. The legislature determines the salaries of its own people. The executives determine theirs. The doctors and nurses are under the executives. they determine what you are going to pay them. If they transfer the doctors to legislature, you see a difference. Okay, but now, just to give you an example of that, Delta State Governor, the former governor, Dr. Oduaga, he came to the United States to shop for doctors for Delta State. And he told them that, look, whatever your salary in America, I'll pay you in Asaba, in Delta. And he got so many doctors to come back home. And he was paying them, I don't know how he did it, But I'm not trying to tell you it's an executive decision. So we just need to take health, isolate health, and don't put it in the structure, salary structure of the country. Otherwise, the UK, I wanted to propose to you that what you're having here today, you should call the British to come and let's talk to them to help us stop taking all our doctors. Okay, or maybe they just send them 2 months back to Nigeria.
I think there is a question about the diaspora thing, but I think I would quickly want to take questions here because of time. So I will start with you and then go backwards. Colleague here in the front, then.
Thank you very
finish soon.
Thank you very much. My name is Mohammed. I work for the government of Kaduna State. I'd like to Commissioner for Budget and Planning. Honourable Minister, I want to disagree with you a little bit. You said that the states don't really care about healthcare. I think that there are exceptions, and I think that there is general concern, even from the political leadership at the top. What we face in Nigeria today, both at the federal and the state level, is we have a challenge of fiscal space for health and other development activities. This is actually quite serious. The federal government is lucky. It's the federal government. You collect the money, you take 54% of it, and we share 24% across 36 states, and then the local government takes the rest. Beyond the resources that you have, you can also print money, you can also borrow. So there's a big difference with the fiscal space that's available for state governments. Beyond that, Honourable Minister, we also have primary healthcare centers. The responsibility constitutionally for healthcare at that level is local governments and state governments by some extent. So when you come back to the issue that Professor Galanishili raised earlier regarding, for example, human resources for health, these are huge amounts of money. Huge when you talk about staffing every single primary healthcare center with medical personnel. When you talk about equipping them and infrastructure. There's actually huge issues that we have around that. And so we frequently divorce the discussion around health with the general and larger economy. And I think Professor Hamala had started to talk about some of that, about the reason why we cannot just take the health, because when you're elected as an executive, you're dealing with an entire package of issues. Sustainable development itself, if you look at the first 5 or 6 goals of it, looks at the unfinished work of the MDGs. But the other half of it looks at how to finance, how to govern, how to ensure that this sustainable development is then sustainable. So I think that we cannot treat health completely isolated, because we also have education issues. We have security issues, we have job issues. So I think that taking that package as a whole and understanding that as a state government what you have is how you can parcel it out to these various sectors. If we keep on having an isolated discussion on health, I don't think that we can ever really achieve that entire full package and have that vision to be able to do that. So we really need to crowd in these discussions. The last thing I want to mention is around political incentives. It's very politically it's not, you don't encourage politicians to invest in health or education because they can't see it. Right? Nobody sees it. Nobody gets elected for providing universal health coverage. They get elected for providing healthcare infrastructure. So I think we need to talk about that.
So I think let's quickly get 2 comments, because
I think his governor accepts that fact.
Quick one,
And I pleaded with him to become an ambassador and talk to his colleagues, and he has accepted. You see, I did mention Kaduna State. Your governor is one that has things on his fingertip. And I've asked the Osun governor to follow. But health, at the state level, other than a few states, nothing is happening.
I think one of the key issues that we haven't been able to have time is the domestic resource mobilization agenda that we haven't touched. Quick comments, please. We need to finish soon. 1, then Rob. And then we'll try and round up. We need to get out of here for 11, please.
Okay, my name is Fatima Abba, and really just my comment, which is also probably going to be a question in this context, is we're talking about the different challenges which is around delivery of healthcare at maybe state levels and then down to local levels, and these are the challenges. And then the senator also mentioned about the fact that we don't implement and then we get states not signing up to things. Do we then think think that maybe for healthcare, Nigeria will benefit from a decentralized system where the federal will manage some of the projects or direct delivery of healthcare, and then the local levels can be then responsible for implementing. That way you cut out some of the bureaucracies, you cut out the numbers of people or teams or groups accountable that you have to hold accountable. It will then tie in with some of the town hall things that we're talking about, where you have a small number of people accountable rather than different tiers of government. Do we think Nigeria will benefit from that?
All right, thank you very much. We'll take that comments. 2 comments quickly. The colleague and the lady in front of him, and then I'll come back to...
So my name is Chikode Analo. So I'm just going to hit on 2 certain points. One is the workforce in terms of some things. So we said we're going to focus more on solutions rather than the problem. So one of the things I want to ask about, are we looking in the direction of trying to create incentive for people to actually want to work in the local government? So for example, I graduate as a doctor, and the next thing I want to do is work in a teaching hospital. But for example, in the UK, I can work somewhere and start working my way up, in the sense that when they want to actually take you in the teaching hospital, they're actually looking at what you have done down. So if I work in a primary healthcare center, do they factor that in when they're trying to take me as a resident, rather than the fact that they only factor in economic, what I know at that point? So those are questions we need to ask ourselves, because if you don't push that growth, that people start seeing it, for example, before you are appointed as a consultant in a teaching hospital, do they actually see your input in the local level? What have you done to earn you that seat on the hierarchy? So in that case, that will take me to the point where we start talking about regional centers of excellence, in the sense that, for example, University of Ibadan today, we know it's an excellence for oncology. So for example, what are you trying to do in terms of trying to make sure that in each region we have one center of excellence where everybody aspires to go there? So I am incentivized to actually work in Oyo State Federal Medical Center, because I know that I want to get to this regional center of excellence, but down here, this is something that is going to make me actually, irrespective of the fact that they might not have the good resources to keep me there, but because I know it is a pathway for me to climb, I will actually want to work there. So the next thing I want to talk about is in terms of research. Sorry, I just want to hit on that, because in terms of research and this thing, for example, the senator has talked about how they've come up with a plan on funding and everything. But the question is, like, for example, I schooled in Sheffield, and one thing I noticed is you understand, the healthcare systems, the government goes to the university to ask questions before they come up with the policy. So you find out that when you are even in the university, they have questions on the table who they are saying, we want students to volunteer to answer these questions. So are we doing that? Are we trying to bring these questions that you have, like the Minister of Health is saying, you have a lot of questions in the Ministry of Health. What are you doing to put these questions out there for those of us who are out there, who are willing to answer these questions, who are ready to do the work to pick up on these things? And how are you going to support that? So those are basic questions I want to ask. Thank you very much.
Excellent. There are 2 good questions, but there are also solution-focused questions, quite the right ones we're looking for. The lady,
Thank you very much. My name is Onyinye. I'm from the University of Cambridge, and I have a communications background in health and governance. And I just want to touch quickly on financing. Rob mentioned that it's very important that we have financing in healthcare, and amongst the work that I've done, I've seen that one of the reasons people do not seek healthcare is because they can't fund it. The senator definitely mentioned the idea of having everyone give, $1 every month. And I think it's a really good idea. I mean, $1 can be easy for some people and not for some other people. But then I think my question here is, has the legislature also thought about how to get that money out of people? Because people are very disenfranchised now about how to give. And then also because we do not really have a very clear system of tracking how things are done in Nigeria. And, so my question is, I think it's a good idea. How do you get people to then give the money?
All right, thank you. I will address that question. Dorcas, one question from my colleague over there.
Thank you. Dorcas Gwata from Zimbabwe, PET advisor. I just wondered what Nigeria's real appetite to learning from other countries is, and that is anchored to Madam's point on research and evidence. We haven't got many things wrong in Zimbabwe. We got quite a lot of things wrong. But one thing we did get right was the Friendship Bench Project, which is a project anchored on the use of community healthcare workers. Now, everyone who works in a healthcare system, including the cleaner who cleans the hospital, is a stakeholder to the system. In Africa, in general, we probably have, Prof, you know, only 3 health ministers of health in the continent are not doctors. One of them is from Botswana, which has reached milestones in terms of achievement. I just wondered if we could open up that space to think about what does Nigeria mean to the rest of Africa, and what does the rest of Africa mean to, and that's anchored to culture, and I think that's very important. I just wondered if I could do just one last question. We in Africa, and who are not Nigerians, look to Nigeria for leadership on many things in the continent, and there are some populations that are not necessarily falling within universal healthcare. We're looking for leadership on someone to take on the issues of xenophobia in South Africa. Xenophobia is a fact, it's a new phenomenon. There are no new policies around this, it's a new phenomenon in a democracy that's trying to make sense of its own populations. Can we really look to Nigeria, not necessarily to lead, but maybe to provide some guidance so that the continent is not disturbed? We cannot continue to firefight an issue which is affecting the entire continent.
Thank you very much. Range of questions here, and we don't have a lot of time, so I will just try and dedicate this 5 minutes. Well, I will give you one chance. You've been persistent with your hand, so just 1 minute for a question, then. The gentleman over here. Then what I will do is to extend some of the comments from colleagues, and then I will ask one final question.
Thanks very much indeed. I'm Ibrahim Bolaji. I'm a consultant obstetrician and gynecologist. I'm also the president of Medical Association of Nigerians across Great Britain. The reason why I'm persistent is because I think there are lots of healthcare workers, professionals in the room, and I want to take that opportunity. The Honorable Minister, at the inception of his position, started off 111. I think he alerted to that very briefly. And the Diaspora Office also introduced Pride and Prime. I think my colleague here was partly responsible for some of those. But about 4 years ago, the 2 programs have been put together. I'm not sure whether you are aware what those programs are. This is about skills transfer from the healthcare professionals in diaspora to Nigeria. So these 2 programs have now been merged together, and they are now called DPHI, Diaspora Private Health Professional Health Initiative. And the components of this includes MONSAC, which is Medical Association of Nigerians across Britain, the National Unions of Nurses, and the president is here with me, and a large number of other organizations across the globe. We have CAMPAD, which is Canadian Association of Physicians in Canada, and we have a group in America, also in Germany and South Africa. So these groups have now come together. I think the Federal Minister of Health has introduced the DPHI, and 3 items have been sent forward to be considered. That's in oncology, renal services, and cardiology. So just watch the space. There's a lot of opportunity for you healthcare professionals in the UK to make your contribution to our motherland. Thank you.
Thank you very much. I will quickly get comments from there. Rob, there was discussion from our colleague from Kaduna State about resource mobilization, and so you wanted to comment about efficient use of resources and perhaps prioritization.
It was really the point, and thanks for setting me up for this. You're suggesting that UHC doesn't win elections. I would like to differ with you on that right across the world, UHC is winning elections time and time again. And I think, to be honest, I think Nigerian politicians are missing a trick on this. If you look in Australia, they're having elections soon. The Labour Party is challenging on a UHC platform to reignite their health reforms. In the United States, it's very likely that in 2020 you're going to have a progressive Democrat taking on Trump, and the #1 domestic issue is health access. And you look at the Labour Party here in the UK, it managed to oust Winston Churchill at the end of the Second World War when he was a world hero on a platform of universal health coverage. And the thing is, it is very visible, and you know, you can get very quick results by removing user fees, providing access to free medicines, making sure the health workers are paid. It's relatively simple to do quite quickly, and politicians are learning this right across the world. And what you're seeing in some big countries that haven't achieved it yet, that are often of a federal nature, that state governors are getting ahead by bringing UHC to their provinces. I give you the example of Jakarta in Indonesia, where the governor came to power with a massive agenda, wanted to do lots of things. He realized that UHC reforms were going to be the things he could do quickly. And within 2 years, he'd introduced it. He ran for president, he won the presidential election, and he's just in the process of being re-elected again, largely on his health reforms. So my top tip to any aspiring, say, governor in Nigeria who wants to be president, run on a UHC platform.
Thank you, Rob. I think we promised, that's good. There are a number of questions that have been raised here, which to me are going to generate a lot more discussion. I like the human resource discussion that colleague raised there around pipeline of becoming a specialist. There are a number of issues about quality of care that we have not been able to address. There's a bit of issues we wanted to pick on around medical detention, Honorable Minister, which we've not been able to address adequately, but we hope we might be able to get some time, another time to do that. We have to quickly now, I will ask a quick question and then we get Ngozi a bit of time to just sort of discuss the Nigeria Health Initiative I was talking about. But starting from Rob, knowing what we have heard so far, you've been quite a close friend with Nigeria for quite some time. If we're looking the next 4 years to have 2 priorities, what will that be? And I'll go around the table to ask that. What should be the 2 key priorities for the next 4 years in terms of USC and health?
Very quickly, that I think that President Buhari still has time to be Nigeria's UHC hero. There will be someone who will do this. And you're seeing President Kenyatta doing this in Kenya in his second term. Don't forget that President Obama brought in the Obamacare reforms in 2012. That would be the top priority, to ensure him that he could be the UHC hero. If he decides he doesn't want to do it, let's find the UHC hero of the future and support them.
So political commitment from the highest level. Yeah. Professor Hamalai, what would you think would be the main priority based on all the discussion we have? 1 or 2 would be, just mention them for me, that would be enough.
I think key is the absorptive capacity of states. States probably cover more than 50% or even 80% of Nigerians in terms of primary health care. And if you don't improve on their absorptive capacity for the 1% or 2%, whatever it is, consolidated revenue funds allocated to basic health care, then we'll continue to have the same problem round and round and round.
So stronger states.
Then the second is the doctors. They need to stop going on industrial strikes every now and then.
Okay. The outgoing chair of our Senate Committee for Health, what would you leave as a sort of focus for the next 4 years, please? What would you think should be?
For the immediate future, maybe over the next 6 months to 1 year, to increase the confidence of Nigerians in the primary health centers. That is to now appropriate the Basic Health Care Provision Fund to develop our primary health centers, so that the people will now be encouraged to pay. Because they are not encouraged to pay because they believe we don't have anywhere to offer them. So that should be the first priority I would suggest. Then the second one is now to encourage, to do a lot of advocacy in the states, our governors, to let them know that it is only a healthy citizen that goes to school for education. Only a healthy citizen that will go to the farm for farming. A healthy citizen that will go for security issues in Maiduguri. So they should not be comparing health to all these institutions, because if they are not healthy, they cannot do all the other things. So health should be isolated and they should fund it.
So I'm hearing states coming around also, as Dr. Professor Hamalai said. Chief Officer of Health in Nigeria, what do you think should be our first key priorities to build on what you've been doing?
Well, I think what is important, in addition to all that has been said, is sustained political commitment and action on the part of Mr. President. I think we are not short of political will, but we need commitment and action. And I will see 2 things happening. 1, accelerated reduction of maternal and under 5 mortality in Nigeria, and a drastic reduction of out-of-pocket expenses, so that you don't have to pay from your pocket, which literally will translate to UHC.
Thank you, Minister. And Professor Galadanchi?
Yeah, I think we need strategic planning based on evidence if we really want to achieve universal health coverage. And I think there should be an effective monitoring and evaluation people should be held accountable and having good governance. And then finally, systematic reporting, which means we get reports so that we can do better. And I think bridging the gap between academia and policymakers is key in achieving these three processes.
So informed evidence, policy, and measurable actions to assess them. Fantastic. Thank you very much, everyone. Before we all go up, I think we promised to have a wrap-up, and Ngozi is here to just help us wrap up key issues and perhaps introduce you to a concept we're thinking about, and then we can do the final side of it. Ngozi.
Thank you, Professor Aliko. Thank you so much, panel. That was fascinating, and I just love Nigerians. They're so passionate, you know. The only time you can come to like a seminar and be like, leave excited is when you're with Nigerians. So thank you so much. So I wanted to tell you about our Nigeria Health Policy Initiative. Do you see that on the screen? Is it there? No? Okay. I'm not sure if it'll go there, so I'll just explain it. So us at the forum, we really want to, actually, you spoke a lot about, yes, do you see it now? Yes? Okay. So this gentleman in the front, I'm sorry, I don't remember your name, but you spoke about, you know, engaging the diaspora, engaging health workers from the different countries. Nigerians are everywhere. There's a Norwegian MP that is Nigerian. Like we occupy the highest levels of government in so many places, as well as we just do excellent work in healthcare. And so, as Professor Aliko said, that we know there's over 10,000 health professionals. I think there's probably more if you look at all the different cadres of Nigerian health professionals. And what we want to do is start a platform to engage with you all. So what we're doing here, but doing it more often, looking at specific policy initiatives that either need to start or that we need to contribute to. And so you can see what the objective is, and we would do this through collaborative approach, engaging in optimizing bicultural expertise. So yes, the diaspora, but also friends of Nigeria. There are some people that are not from Nigeria that know more about Nigeria than many of us. I have a professor who speaks Hausa. He's an 80-year-old Englishman, so it's good to have the diaspora as well. And then focus on solutions based on, like I said earlier, these existing assets in Nigeria, so we can ensure that this is sustainable. It's just not people from the outside talking about what needs to happen. And so what would be the outputs of this type of platform? It would be independent policy analysis and policy recommendations to the government and other interested stakeholders. And I think what's encouraging about this is that we already have such commitment from government. We already have a great partnership and relationship with the Honorable Minister, as well as the distinguished Senate Chair. Even though you're outgoing, you can put in a good word for the next chair. So what we're asking you all to do is to be involved with this new initiative. And how do you do that? Well, you have to actually become a member of Chatham House. So you won't only have access to this initiative, but you also have access to private events. This is a private event. Each one of you were invited because of your expertise and your experience, but often you can only come to private events if you have a membership with Chatham House. So you can do that through, we have some forms here on the table, but you can also just do it online. You could have an individual membership or you can have a corporate membership. We also, a lot of you represent different organizations. We're encouraging you all to talk about this initiative so we can receive philanthropic donations and research grants for specific projects that we may undertake. Chatham House is a registered charity. It has clear funding guidelines, and we're happy to provide that to you as well, but I think that's online also. So for further details, please contact directly Professor Aliko, also our program coordinator, Ali, who's in the back over there, and these are their details. So, anything else?
No, I think thank you very much. All I will say is that this has been to us a very helpful session, a very incisive and enlightening session. I hope we had a lot longer time. When you are talking about Nigeria, you can talk it for days, I'm sure. So this is generating some solutions, but also raising a lot of other questions that perhaps we'll come back to. But we completely believe that for Nigeria to be able to achieve a sustainable improvement in health, we have to look at the assets that are within Nigeria. The cultural, the social, the economic, and the intelligent assets that is within the country. we all know that development assistance for health from international partners is not likely to be increased. For the last 10 years, it has actually plateaued or dropped. Nigeria had to find a means of mobilizing as much resources as it has internally and utilizing its own human capital. And I think sessions like this are intended to do that. And we have a brilliant mindset outside Nigeria, hence why we are having this session here, because Nigerian leaders are coming to speak to the global community and to leverage all the Nigerian assets we have, how we can help to support Nigeria. And thank you very much, members of the panel. This is a very insightful session. Thank you very much for your contribution as participants, and we look forward to seeing you again another session. Thank you.